Good morning, everyone. I'm Agnes Lee from Vancouver, Canada, and welcome to our first CanVector National Thrombosis Seminar. It is 9 o'clock my time and 6 o'clock in Switzerland, and we're going to give folks a minute or so to just get on the webinar. If anybody is like me who has technical challenges, we're going to give you a little bit of time. So already I could see that my slide has been automatically forwarded for me for some reason. I hope this isn't going to be the case going forward. Oh, and somebody's moving the cursor as well. But that's okay. We're back on the first page. And just to warn everybody, this always happens to me. If there is a technical glitch possible, it is going to happen on my time. And I don't know what it is. I have this force field that managed to melt down any sort of, foolproof ways to get seminars going. But anyways, so I don't want to delay things because this is our first seminar and we want to be on time. So I'm gonna go ahead. And so welcome everybody who's attending our first CanVector National Thrombosis Seminar. And perfect. Okay, so it looks like the slide is now advancing when I want it to. There does seem to be a bit of delay. I'm not sure what it is. I'm happy to be presenting today along with the winners of our CanVector COVID research grant, Drs. Ed Conway and Dr. Tobias Trichler on COVID-19 and thrombosis and related research. Now, we are as you know, the CanVector National Thrombosis Seminar is a new activity launched recently, and this is going to be featuring state-of-the-art presentations by CanVector faculty and trainees, both from within Canada and internationally. The seminar series is accredited for a 1-hour section 1 activity by the Royal College, and we invite you to complete the evaluation at the end. The link will be sent to you, and so that you can claim your points. But before we start, I want to give special thanks to our planning committee from across Canada who helped to put this together. And they will also be helping to invite our future speakers for this seminar series. Now, for today, I'm going to give a brief summary of the incidence of thrombosis in COVID and talk about the concept of immunothrombosis as a mechanism of thrombosis in COVID. I'll be followed by Dr. Edward Conway, who's the director of the Center for Blood Research in Vancouver and professor of medicine at UBC. Ed has a well-funded research lab that has long devoted to understanding the molecular links between coagulation and innate immunity. And we will wrap up with Dr. Tobias Trichler, who's a general internist in Bern, Switzerland, who completed his thrombosis training in Ottawa, and he will share with us his research on anticoagulation management in hospitalized COVID patients. So at the end of the seminar today, there will be a 15-minute question and answer period. Just to make sure we stay on time, you can type in your questions in the chat box and we will address them all at the very end. And hopefully this will also avoid any technical issues that I always manage to seem to create. So I'll just start with my talk now, and hopefully there hasn't everybody who's been who wants to join us has already gone on, and I'm already seeing that this doesn't seem to be advancing. Okay, we will see what happens. So anyways, the learning objectives for my summary is to review the incidence of thrombosis in COVID-19 and to introduce the concept of immunothrombosis and understand the potential role that it has. So that's me. So to start with, I don't have any relevant disclosures for this talk. Perfect. I think I'm actually now finally on my first slide. And like I said, so as many of you know, COVID is associated with thrombosis. And although this has been termed COVID coagulopathy, this is a clotting disorder and not a bleeding disorder, which we commonly associate with coagulopathy. And if you look at the coag abnormalities in patients with COVID, you can easily understand why these patients are prothrombotic, because they have very high levels of fibrinogen, factor VIII, and von Willebrand factor, all of which will increase the risk of thrombosis in these patients. Now, the reason why it may be called coagulopathy probably dates back to the origin of the initial studies from Wuhan, China, that reported many patients died with DIC when they developed COVID. And in fact, in one study, 71% of the deaths were associated with DIC. Now, these studies also described a very strong association between severe COVID infection and elevated D-dimer, and many studies have now shown that high levels of D-dimer are predictive and are correlated with increasing disease severity, including the need for critical care support and mortality as well. And one study found a significant reduction in mortality with low molecular weight heparin thromboprophylaxis, and that basically launched a lot of questions about whether anticoagulation will improve outcomes in these patients, just sort of on top of just the protection in terms of thromboprophylaxis, but whether there are other potential mechanisms. Strangely, I have to say though, all of the initial experience in China did not report any thrombosis complications in these patients. Now, if we actually move ahead to what happened in Europe, when COVID spread to Europe, again, there wasn't really this idea of a high thrombotic event rate because this wasn't reported in China. But very soon, it was reported by European colleagues that high incidence of thrombosis were being seen, particularly in patients in the critical care unit. Now, on this slide, I've just summarized a few sort of selected studies from various countries in Europe, and clearly by no means shows the total number of studies that have now been published. Almost all of these are retrospective, often single-centered. So a lot of methodological issues with some of these studies, but they do consistently report a higher incidence of thrombosis than what we expect, and many patients are breaking through thromboprophylaxis. Interestingly, all the studies show different rates, and this may be due to the different ways the data is being collected, whether screening ultrasound is being used, and also interestingly, increased risk of line clots and extra corporal circuit clots were also being reported as well. Now, when we get to the US, and other sort of pattern emerged in that they were reporting a higher incidence, but lower thrombosis rates compared to Europe, and a little bit higher than China. And again, we still don't really know why, but perhaps this is due to sort of more consistent escalation of the intensity of thromboprophylaxis given to these patients because they had heard about the high incidence of thrombosis in Europe. Here in the US as well, they were also starting to report a higher incidence of arterial thrombosis, and definitely the extracorporeal incidence of thrombosis were increasing as well. So finally, most recently, we have some data on post-discharge thrombosis, and I have to admit, somewhat surprisingly, there's a very low incidence of post-discharge VTE that's been reported at approximately 0.5% over the first 30 to 42 days. Clearly, we need more reports, and because these studies are, again, limited in terms of the retrospective methods, and a lot of confounders are involved. And we're really happy that Deb Siegel from CanVector has received funding from CIHR for the Virtuoso study, which is going to be looking at this area prospectively. So why are all the differences being observed in thrombosis rates? So besides the methodological issues, I think there are additional personal or individual patient risk factors, including racial differences in VTE risk. Perhaps the weights are different among patients, and so if you use a fixed dose of thromboprophylaxis, this may be underdosed in some patients and overdosed in others. Whether smoking has an impact is interesting in that clearly there are more smokers in the Chinese population. Prophylaxis, I've already mentioned the intensity sort of vary throughout this period and not routinely given in China and almost given therapeutic intensities in some parts of Europe and the US. The types of antiviral therapies and clinical trial experimental therapies that have been used may have an impact on thrombosis rate. We don't know as yet. And clearly ICU capacity as well as the criteria for admission in various countries will have an impact on the event rates that are reported. We know that confirmation and certainly suspicion bias varied all over the place, and imaging for confirming or excluding the diagnosis of PE or DVT isn't always feasible. And finally, it's now emerging that immunothrombosis may be an important mechanism in these patients, and that this is a mechanism that is highly individualized, and it may reflect genetic propensities in patients in developing thrombosis. So what is immunothrombosis? Well, this is a physiological reaction, actually, or physiological thrombosis that enhances the innate immune response against pathogenic insults. And it does this by localizing the activation of coagulation in microvessels of the infected tissues. The fibrin generated then sort of provides this scaffolding or trap, if you will, that facilitates the recognition, containment, and destruction of pathogens. So this is a very efficient coordination of the coagulation system, as well as complement the inflammatory response and contact pathways. And all together, these systems basically form the underlying immunothrombosis mechanisms that are supposed to help us fight viruses, bacteria, and other pathogens to shut it down. Now, this slide gives you a little bit more details about the various mechanisms that are that sort of comprises, and so I'll just walk you through a little bit on this. And I apologize if the graphics are a little bit too small. I can't really tell what on your monitors whether you could see this clearly. But in response to pathogen or damage associated molecular patterns, all right? So these are bits that are sort of from viruses or bacteria, and these will basically initiate monocytes to produce or express tissue factor bearing microparticles, which, as all of you know, will initiate the extrinsic pathway. Also, neutrophil extracellular traps or nets will be released by neutrophils, all right? And this basically then produces this lattice of DNA and histones, which traps a lot of inflammatory and coagulation activators within the area to initiate the contact pathway, further basically activate platelets. It will also inactivate anticoagulant pathways and also initiate complement. So as you can see that these mechanisms really can sort of isolate and concentrate the attack and shutting down of local infections. And Ed in his talk will tell us more about how complements may be involved and how it may be important to shut down this pathway in COVID infection. So, although immunothrombosis is meant to help us react to infections, a dysregulated netosis or dysregulated a reaction or hyperreaction, all right, which can occur in acute and chronic inflammatory conditions, all right, including ARDS and sepsis, can unfortunately cause damage to the tissues itself. And in COVID, this seems to be a contributing mechanism. And recently, a paper in Blood did demonstrate that net formation correlates with disease severity, the need for intubation, as well as death in patients infected with COVID, and that the net containing microthrombi has now been confirmed in lung specimens from COVID autopsies. So how do we sort of put all this together? Well, clearly in COVID, the virus infects pneumocytes and endothelial cells via the ACE2 receptor. And this is followed by an influx of macrophages, neutrophils, lymphocytes, which initiate the innate immunity and immunothrombosis. Unfortunately, with large load infections, we end up with massive endothelial cell apoptosis from the COVID, and this leads to further tissue factor activation and further intravascular thrombosis. And the increased permeability from complement and contact pathway activation probably leads to the intraalveoli fibrin deposit. And it is felt that it is this intraalveoli fibrin deposit that's contributing to the sky-high D-dimers that we see, particularly in the patients who are doing poorly. So another mechanism that has now been proposed that may be important in COVID-19, not surprisingly, is antiphospholipid antibodies. And I'm not going to go into this into detail, but just to summarize in this slide, some of the studies that have now reported a high incidence of lupus anticoagulants described in selected patients. So for example, in this study with 57 patients in the ICU, all the patients who have clots or prolonged PTT had a lupus anticoagulant tested, and you can see 88% of these patients were positive. They did not measure anticoagulopathin antibodies or anti-beta-2 glycoprotein 1 antibodies. And in this even smaller study in the UK, again, they found 92% of the patients tested positive for lupus anticoagulant, but all of these had a prolonged APTT in a positive mixing study. So again, a highly selected population, but it is possible that lupus anticoagulants or anticardiolipin antibodies may be involved in particular arterial thrombotic events that we are seeing in COVID patients. So in summary, SARS-CoV infection leads to massive alveolar and endothelial injury that probably contributes to a dysregulated immunothrombosis and systemic coagulation. This contributes to a high incidence of thrombosis in these patients, and it does certainly correlate with increasing severity. The variation in thrombosis rates probably reflect differences in the methodology in the studies, but also in individual risk factors, including perhaps genetic determinants of immune regulation. And NET certainly seems to be playing a significant role in microthrombi formation, and the significance of lupus anticoagulant and the role is still uncertain, but certainly a very provocative mechanism as well. And because of this underlying immunothrombosis aspect to COVID-19, we probably need to look at other therapies in addition to anticoagulants in order to attenuate and treat the prothrombotic mechanism in COVID-19. And so thank you very much for your attention. And I'm now going to hand over the control to Ed, who's going to tell us a little bit more about complement in COVID-19.
All right, where did that slide come from? I'm just waiting for, this is Ed Conway, and thanks Aggie, that was fabulous. I'm not sure I have to do anything. You've done it all, actually.
Oh, no.
Here we go. Okay, I think I'm in control. doesn't happen that often. All right, thanks. So Aggie, you did a fabulous job. I can hardly add to that, as a matter of fact. So these are the disclosures. Many thanks to CanVector for supporting this project. There's additional funding from fastgrants.org and MyTax and my Canada Research Chair, and there's no other disclosures. And as Aggie has pointed out, there's obviously lots of clotting associated with coronavirus patients, which is major cause of morbidity and mortality. Insights have been gained from a mechanistic point of view from pathology. There aren't a lot of autopsies on these patients, but in many cases they do have large vessel thrombi with pulmonary emboli and deep vein thrombosis. But most striking is the parenchyma, and this is of the lung, with small firm thrombi in the alveolar capillaries with swollen thickened endothelium, intravascular fibrin and platelets, and perovascular leukocyte inflammation. But notably also there's a deposition of complement fragments, in this case C5b9, C4d, and MASP2. And I know that you are all very familiar with the complement pathway. So I know you love cascades, because that's why you're all clotters. But the hypothesis here is that the SARS the virus associated with COVID-19 triggers complement activation, which in turn triggers coagulation, and then you get feedback amplification of coagulation activating complement, and you get this sort of cyclone sort of situation, which is very difficult to stop, and it's associated with inflammation. So how does this work? Well, first, you know about the coagulation system, the complement pathway. It's an innate immune response to invading pathogens and damaged cells to get rid of them and to promote healing. And it's triggered via three pathways: the lectin pathway, classical, and alternative. And I won't go through these in any detail other than to show that they all converge with conversion of complement factor C3 to C3b. And it's at the lectin level, it's triggered by carbohydrates, which the SARS virus carries lots of, and the classical pathway, which are immune complexes, of which happens in SARS, and you've already heard that. And once it's sort of got to this point, it sort of self-amplifies, and then if it exceeds a threshold, it's just like coagulation. If you get enough thrombin generated, you'll get a clot. Similarly here, if you get enough complement activation, you get conversion of C5 to C5b, which assembles with other complement factors to create this massive so-called membrane attack complex. And at each step, there are various fragments, little fragments, and it's the little things that are important here that sort of trigger the complement system. And these little fragments tag those damaged cells and pathogens. These fragments, this is the C3a and C5a, are anaphylatoxins. They recruit the inflammatory immune cells so they can get rid of those invading pathogens. These here recruit adaptive immunity for subsequent immune response and healing. And finally, the membrane attack complex, which destroys the pathogen and damaged cells. Now, how does that all convert to complement activating coagulation? Well, this is a complex system, and in 5 minutes, I certainly can't give it any degree of justice to show how these crosstalk, but they do indeed crosstalk at many levels. But I'll just give you an example, and on Aggie's slide, she points out that C5a, which is that anaphylatoxin, activates platelets in a variety of ways, promoting coagulation in that manner. It activates endothelial cells, inducing tissue factor, releasing microparticles, and inducing vascular permeability. And it activates leukocytes, neutrophils, and monocytes, which promote nets formation, as well as by monocytes, tissue factor, cytokine release, that's your IL-6, the so-called cytokine storm. So it promotes all those things. Now, coagulation just doesn't sit by passively, but as complement induces coagulation, coagulation feeds back, as I pointed out, and thrombin can directly activate complement by cleaving C5 to release this C5a, which in turn, again, promotes coagulation. So making it simple, here you have the SARS virus that induces changes, that triggers complement activation, coagulation, which lots of thrombin feeds back, and here you have your cyclone situation, which is difficult to turn off. Are there examples of this in other diseases? Yes. You may or may not be familiar with rare diseases, atypical hemolytic uremic syndrome and paroxysmal nocturnal hemoglobinuria, or so-called PNH, both of which are caused by excess complement activation due to loss of function or gain of function mutations in the complement system. Those are associated specifically with microvascular thrombosis in atypical HUS and macrovascular thrombosis, large vessel thrombosis in PNH. And those are major causes of morbidity and mortality. And how do we treat those? How do we treat the thrombosis in those? Not with anticoagulants, but rather with anti-complement drugs, and very effectively so. All right, so what's this all got to do with SARS? So the question is then, is complement participating in SARS coronavirus associated thrombosis? How is it being done? And can we gain some useful information? That's the purpose of this proposal, supported by CanVector. There's two major aims. The first aim is based on collecting serial plasmas, so daily bloods from patients with COVID-19 infections, and we've collected in collaboration with groups here at UBC over 40 patients with serial bloods, and on those patients we're measuring levels of complement factors, C5b9, C5a, these shown, and others, as well as coagulation, as well as a variety of inflammatory cytokines, and we're correlating that with the clinical status of these patients. We already know that these complement levels are sky high, and certainly IL-6 is sky high, and whether these correlate or are predictive, it remains to be seen. In the second part of that aim, we're taking all those plasmas and we're culturing endothelial cells, and we're looking what do those plasmas do to the endothelial cells. So we're incubating them on endothelial cells, which induces presumably damage, complement deposition, and we're measuring thrombin generation and plasmin generation, among other things, to see if there's a direct effect. And with that, then we can add various inhibitors at different steps in the complement cascade, as well as the coagulation cascade. We can do these in combination sort of treatments and trying to gain sights from a therapeutic point of view. How do we turn off that cascade that I showed you before? Now, in a similar manner, in the second aim, we're taking proteins from a variety of proteases from the SARS coronavirus 2. These are recombinant forms. There are many proteases generated from the virus, and we're adding it to healthy plasma or serum, and we're incubating again with the endothelial cell and looking at complement activation and thrombin generation. And by the same approach, we're looking at inhibitors to see at what step can we turn this off. And in the end, what we hope to do is to characterize links between the virus, the viral infection, the proteases generated by that virus infection, complement coagulation, and thrombosis, and hopefully to identify predictive markers. Well, I'm out of control here. All right, can we just go back to the list of people? Because that's important. Back, one more. Were you guys trying to make? You can stop there, okay. And we hope to get predictive insights into predictive biomarkers as well as therapeutic interventions. The team is Alex Letherdale, is a postdoc who's just arrived from McMaster, and Kevin Gonzalez, who's a master's student in my lab. And this is in collaboration with Ed Prysdale, who's a CBS CBR investigator, and his master's student. Christoph Litz is a investigator at Sick Kids in Toronto. Natalie Stranatka is a CBR investigator who's making all the recombinant proteins. MIP and Cheryl are the investigators here who are collecting the plasmas from the patients. And thank you very much.
Hi, everyone. It's Tobias Trichler from Switzerland. Many thanks for the invitation. It's a great pleasure to be here today. I try to forward the slides. I have no conflicts of interest to disclose. So I have the privilege to present today our study, Anticoagulation in Hospitalized Patients with COVID-19 an individual patient data network meta-analysis of randomized controlled trials in the name of a fantastic team who was enthusiastic about this project right from the beginning. And in the name of this team, I also want to thank Ken Vector for the funding and the support of this study. As you all know, we have seen a really unique speed of trial development in the last months, which this graph aims to summarize. You can see the number of completed or ongoing studies on the y-axis for a specific intervention on or drug on the x-axis. And hydroxychloroquine, unsurprisingly, is the big leader with more than 175 trials. But also enoxaparin has made it to this chart, and this is mainly because one of the important questions in the care of patients with COVID-19 is whether anticoagulant interventions at increased doses improve outcomes when compared to prophylactic doses. However, the approach to this important question was from a global or even a national perspective, at least initially, disorganized or fragmented, because it's very difficult to establish such large trials with multiple sites in such a short time. And now we have many trials assessing a similar questions. And even though those trials have been developed at like an incredibly fast speed, the pandemic has peaked at several sites before those studies were started. And as a consequence of this, or by the study design, individual studies may be too small to assess rarer but important outcomes or important subgroups. And finally, none of the individual studies assesses or compares all available interventions. So for example, none of the studies really compares therapeutic to intermediate to prophylactic intensity anticoagulation. And even within the trials, the intensity of the anticoagulation varies in the comparator group due to different local standards. To address these issues, we propose an international collaborative project that has three aims. First, we want to compare 30-day all-cause mortality in hospitalized patients with COVID-19 receiving prophylactic, intermediate, therapeutic, or other intensity anticoagulation. Second, we want to compare the frequency of secondary outcomes such as major bleeding, VT, arterial thrombosis, or mechanical ventilation. And third, we want to assess the efficacy and safety of anticoagulant interventions across subgroups. The method which we propose to achieve this objective is an individual participant data network meta-analysis of RCTs evaluating anticoagulant interventions in hospitalized patients with COVID-19. The project has 4 steps. First, we conducted a scoping review to identify eligible trials. Second, we want to establish an international collaboration. Third, we will conduct the IPD and MA. And finally, we want to disseminate our findings through various channels. We have completed the first step of the project this summer. We identified 20 RCTs which evaluate anticoagulation in COVID-19. Most studies include ICU and non-ICU patients. 14 evaluate therapeutic intensity anticoagulation versus standard dose or local standard prophylaxis. And most studies use a composite outcome, of which the majority includes mortality as a component. Once we identified the trials, we reached out to Invent-VTE for a collaboration, and Invent invited PIs from all studies to take part in a call for action to collaborate and to participate in the proposed project. And as of now, PIs from 13 out of 20 trials responded positively and also joined us in this recently published call to action. So overall, the project and the number of collaborators is growing fast, and I really have the privilege to speak here for a great team and steering committee whose individuals contribute to this project with their expertise in various fields and are really crucial to the success of this project. Currently, we are finalizing the protocol of the study. We will soon prepare data sharing agreements and standardized data extraction forms. And we will then decide collaboratively in the steering committee when to start with data extraction based on the available data, the published studies, anticipated future recruitment rate, and the global situation of the COVID-19 pandemic. But overall, we intend to complete the project by next fall. So that's it already from my part. I really thank you for your attention, and I'm happy to take any questions.
Thank you very much, Ed and Tobias. Those are great projects, and congratulations on your grants. Makes me feel not so bad that I didn't get it after all. Now, so we're going to open the seminar to questions and answers now. And so for those of you who may not be familiar, there is a chat box function for Zoom. And if you click on the chat, you can actually enter questions, and well, I think we can see all of them, and certainly we can go through them, and because it looks like we've got lots of time today, so that's great, because I certainly have some questions for Ed and Tobias as well. And I'm not sure that we're able to open the question format live. I forgot to check that with Caleb and Jesse at the beginning. So, but folks, again, if you have questions, please type them in, and I'm going to sort of go through them. Maybe while people are just typing questions in, Ed, I have a question for you in terms of complement. So as you probably know, recently there's been data that dexamethasone will help will improve outcomes in patients. And there's been a lot of sort of controversy about when steroids may actually be effective, whether we should use it early or late. And certainly looking at the clinical trial, the recovery trial, it looks like patients who had symptoms sort of like within 7 days didn't seem to have as big of an improvement compared to patients who actually have had symptoms for 7 days or longer. Like, is this something that you think is, reflects the sort of the immunothrombosis or complement activation? It's sort of like these more downstream problems. So not so much the initial viral infection itself, but it's all the downstream. It's really the host response that's kind of unfortunately killing us.
Yeah. I mean, it's a good question. One, I don't have an answer to your question. The effects of this corticosteroids on are so varied and widespread. They undoubtedly have effects on endothelial function. I don't know that there's ever been studies on the direct effects of corticosteroids on complement activation, certainly not in vivo. I don't know that literature, if it exists actually. So that would be interesting. And in terms of, early versus late, I mean, I'm a major proponent, just that, I believe based on the data that we have and others have in terms of complement activation, that, as soon as patients are walking into hospital, no matter how ill they are, but it means that they're somewhat ill, they all have elevations in complement activation and probably inflammatory cytokines. So my philosophy would be, early treatment in all these patients. And the fact that you don't see as big an effect with corticosteroids, I'm not really sure what the relevance of that is. I don't know.
Yeah, I mean, certainly very interesting. And, as you know, there are lots of clinical trials looking at suppressing the cytokine storm with, IL-6 inhibitor and so on. So now, so we have questions with Tobias as well. So do you have any updates on the progress to individual trials and any contingency plan for your study if some of them don't complete, for example?
So the plan, or regarding the update, I do not have any specific updates for the trials that participate. I know from one trial, the ATTACK trial, which is a Canadian trial that enrolls patients also in the US and Mexico and Brazil, that trial is doing actually really great and starts enrolling at an excellent rate. But I also know that some other trials are slow in enrolling and also due to the current situation of the COVID pandemic with fewer patients, especially in Europe, at least until recently. With regard to if some trials do not complete, the plan is that we meet from January onwards on a monthly or basis with the steering committee to assess the published literature, hopefully, and decide collaboratively whether we want to start with data extraction and analysis, depending on what we anticipate for future recruitment, and also depending on the global pandemic situation. And since all the PIs of the study are participating in the steering committee, I really hope that at that point we'll have more information with regard to the recruitment, whether they meet the recruitment targets and what the plans are. Yeah.
Yeah, I mean, certainly, I mean, I can say locally in Vancouver, for example, we've had, relatively low hospitalization rates, even with our first peak sort of thing, where our numbers are now going back up, but the hospitalization rate has remained low. So it's been unfortunate in some ways because we haven't been able to contribute to many randomized control trials because our numbers are so low. So, my scientist hat, I'm thinking, I wish we have more patients. And then, of course, my more reasonable hat perhaps is like, no, we got to keep these numbers down. So, so do you have a lot of centers, for example, like in Brazil and India, for example, where the numbers are just continue to skyrocket?
So I'm not, I don't know if any of the studies are enrolling in India yet. I think there are some issues with the regulatory agency with regard to the funding of the studies and how much participant sites would receive per patient. But ATTACK really recruits in Brazil and Mexico at a good rate, and obviously also in the US. So the most of the patients that are recruited into ATTACK are from those sites. Yes.
Yes. So I have good information here from Mark Carrier and Susan Kong that the ATTACK leading recruiters are Brazil, Mexico, and the US actually. So so that's good to know, and hopefully, with the great international collaboration you have for your study, we'll be able to, definitively address some of these questions because clearly they are very important. Another question we have actually from Leslie, also relevant to treatment, and Ed, please feel free to chime in as well. So, with immunothrombosis as well as arterial thrombosis being described, do you think there is a role to add aspirin to low molecular weight heparin thromboprophylaxis? I mean, should this perhaps be, added to standard prophylaxis? It seems like a relatively benign, certainly a better understood drug compared to, some of the other drugs that we're studying. It seems certainly inexpensive as well. Are you guys aware of any study that's looking particularly at aspirin, or do you think any mechanism that aspirin may be particularly helpful in shutting down complement or immunothrombosis? Maybe Tobias.
Well, Tobias could talk to if there's any clinical trials. I'm not aware of that. Is that, do you know, Tobias?
From a clinical trial perspective, I think there is one German trial that assesses, like in a 2x2 factorial design, rivaroxaban and clopidogrel. So patients receiving either rivaroxaban and clopidogrel, or rivaroxaban placebo, or clopidogrel placebo, or just placebo. But I'm not aware how well they recruit. What I certainly know is that, for example, the ATTACK trial, which is collaborating with the REMAP-CAP trial, is a platform, or the REMAP-CAP is a platform trial, and the established collaborations will probably in the future assess that antiplatelet agents as well. So they have the network and to assess those agents as well.
To address that and actually answer a question that Mark Roger has raised in terms of other approaches. I mean, could you use aspirin? I guess you could. I mean, from an antiplatelet point of view, it's not totally unreasonable. I'm not sure if it's the best way. I mean, quite frankly, I'm favoring, and I'm somewhat biased, I'm favoring an anti-complement approach and a direct anti-complement approach. And there are clinical trials going on certainly in Italy, and there have been anecdotal reports out of New York early on using eculizumab, but there's others as well. The Apellis has a C3 inhibitor. So there are a variety of approaches to try to turn off complement. The challenge there is the eculizumab trials they're giving these late in the course. So, and I don't know that that's the best way. I understand why they're a little antsy about giving drugs early, and particularly when you're turning off the immune system. I think that's a low risk relative to the potential benefit. I think it should be given earlier. Patients do very well with eculizumab, and the risks are very, very small in the greater scheme of things. So, and that in theory should turn off the complement activation, which in turn should turn off activation of platelets and the endothelial activation.
That's so Ed, it's good to know that eculizumab is being investigated, but you probably know, like in Canada, for example, the cost is prohibitive, right? Like there's just
they'll release it. Yeah, they're releasing it on a compassionate basis for this purpose, for this study. So it's part of a study. Nobody's bought in yet. I'm not sure how widespread the news is. It's been available for a while, like almost from the very start, that it can be obtained. So for this purpose, and nobody's jumped in yet in Canada. I don't think there's a case it's being used for, but it's available.
I see. Yeah, I mean, I sit on the provincial COVID therapeutics committee where we talk about all the randomized trials that we're participating in.
Yeah.
And this hasn't come up at all.
Okay.
But again, the cost in here in Canada. I'm sure
that's unfortunate that word is out, because it's not going to cost anything. So it's just a matter of connecting. So
but what I mean is, like, yes, if you participate in the clinical trial, the study drug is covered. But even if we found benefit, it may be very difficult to implement. Like, for example, right now, we have, discussions about remdesivir, which is only about $3,000 a shot sort of thing. And we have limited drug supply, but, we don't really know that we could even afford $3,000, right, given just the number of patients. So eculizumab, which is something like $250,000 a year or something for treatment in PNH and so on. I think people are just concerned. Like, there's kind of no point studying a drug, perhaps, if we can't afford it. But I mean, that's a different argument for another day.
Right. But you're not going to give this drug long term. This is a short term situation, so it's not costing $250,000.
That's true. Now, there's the Scott Katz. So welcome, Scott. He's commented the NIH active 4 outpatient trial has 4 arms with prophylactic and therapeutic apixaban, ESA, and placebo as well. So hopefully we'll be able to answer more questions. So since I don't see any questions, but my last question, actually, if I may, Tobias, I don't remember you mentioned, are you guys looking at bleeding outcomes as well? Because that is also emerging, as a concern when we're using, these high doses of anticoagulant therapy. I think one of the UK ICU studies did report a high incidence of major bleeding. It's not consistently reported in other reports, so it's really hard to know. And as you know, major bleeding is difficult to, it's actually a difficult outcome, right? And so, and patients seem to be having bleeding at unusual sites as well. Is that being captured in your study?
Yes, so first I absolutely agree, and it will be as one of the secondary outcomes, and I think most of the trials, at least the ones which we already have now, the CRFs, or which reported on clinicaltrials.gov, are capturing major bleeding as well, based also on the balance of thrombotic risk and bleeding. Certainly, it will be one of the challenges to compare those bleeding rates, as it will be to compare the thrombotic rates due to different definitions and also different ways of adjudicating those outcomes. And this is what this challenge we are aware of, and I think even the individual trials will face, or certainly face, this challenge. And this is also one of the reasons why we decided to do an individual patient data approach, where we can really look at those outcomes in a meaningful way.
Thank you. And I think I see a question actually from Mark Roger. Sorry, I missed it earlier. Related to something Ed's already talked about. Any therapeutic options targeting complement that may be effective in reducing the cyclone?
That's what we talked about, right?
Yeah.
The eculizumab.
So, I mean, obviously you're biased, Ed, in terms of complement, but if, you know, just looking at what we understand now, what about NETosis, for example? Are there therapeutic modalities out there addressing NETosis? And are you aware of that at all? Anybody working on that?
We need the NETosis people in Alistair to give their DNA drugs. Yeah, I don't know.
Yeah, I mean that certainly, again, it's interesting, but perhaps then, you know, the viruses would then just, you know,
Don't know.
unfortunately as well. But given the limitation of, you know, ACE2 receptors in the body, right, I suppose that may actually be reasonable as well. And so I was hoping that maybe Pat Liao I thought was working on something about looking at DNAs and perhaps even anti-thrombomodulant therapeutics and stuff. So, but perhaps Pat is not on the call, so perhaps we will ask Pat offline. We have a few minutes to go, but I just want to sort of actually bring people back. If you haven't submitted your questions, please do so. And also, if I could, Caleb, get back to the slides. I think we have, perfect. Just so, yeah, in the time remaining, I just want to, again, thank everybody for attending today. I think we have 40 participants, so this is a great start. And our next seminar will be in November, mainly because in October will be the CanVector virtual conference from October 13th to the 24th. So for anybody who hasn't registered yet, please do. This is free registration, of course, and we have some fantastic presentations lined up. The November topic hasn't been selected yet, but the planning committee and I will definitely try to nail down a specific speaker and topic because we know everybody's busy. As something different for this seminar from other types of seminars is because we do recognize that everybody is busy, and that if we actually picked a specific time on the same day, you know, sort of like the third Wednesday of every month at this time, then there are going to be people who will be missing this consistently because they may have clinic all the time during this time. So we thought to try to attract as many people as possible and to also really be flexible to speaker and audience availability. We are going to move the time and the the day of the week, like of the talk each time. Hopefully this will really allow people to participate more, and we are aware of the time differences and the time zones. So we will definitely let you know as soon as we know who the speaker and the topic is for November, so people could sort of block the time. It looks like today's time slots actually worked quite well for people. So we may pick this time slot again. And if you have any particular topics or speakers you would like to hear from through this seminar series, we certainly welcome your feedback as well. And so perhaps we will just end the 5 minutes early because it looks like we don't have any more questions. But Ed and Tobias, before I wrap up, maybe do you have any questions for anybody? No? Yes? Good?
Oh, thank you. Fabulous.
All right. That's great. Well, I certainly enjoyed it. I think this is going to be a great seminar series. Again, this is not to compete or replace any local seminars. We really want to have, sort of state-of-the-art presentations, getting our trainees to highlight their research and really focus on specific topics that's, near to dear to CanVector. So I want to take this last minute to thank Jesse and Caleb for helping and organizing. So technically I didn't destroy anything, I hope. And I also want to thank Susan and Mark for always their outstanding leadership. And this is, their idea in the first place. And I think this is a very, very good activity, and hopefully we'll expand this to the international level as well. So thank you everyone again, and have a good day. Enjoy the rest of your lunch out east. And Tobias, enjoy your evening. Thank you very much, Ed and Tobias, and congratulations again. Bye-bye.
Very much.
Bye.
Bye, everyone.